In this video, we're going to talk about a medical assessment of a patient. The first thing we want to do is make sure that we have our proper PPE and that the scene is safe. We'll then go ahead and determine the nature of illness or the mechanism of injury. We'll then go on and determine how many patients we have, and then we'll call for additional resources. And then we'll go and always consider C-spine immobilization. Next, we want to form a general impression of the patient. What is the patient presenting to us and how we see the patient? And then we're going to determine a level of conscious. Is the patient alert? If they're alert, we'll ask them 4 questions: person, place, time, and event. If they answer those questions correctly, then they will be alert and orientated, and times 4. If the patient is not alert, we'll go ahead and try to stimulate them verbally. And if they don't respond to verbal stimuli, we'll go ahead, give them a sternum rub and pinch their ear. If they don't respond to painful stimuli, we'll consider our patient unresponsive, and at that time we will be calling for ALS and managing their airway. If the patient is alert, they can go ahead and give you a chief complaint of why they called 911. And then we're going to go and talk about the X, A, B, C's, and S. X stands for external bleeding. We want to control any life-threatening external bleeding on the patient, and we want to make sure the patient has an airway. If they're alert and talking to you, they have a patent airway. If they're unconscious, we'll go ahead and pull their oral airway in. If there's any kind of gag reflex with the oral airway, we'll remove it and consider a nasal airway. And we'll go on to determining their respirations, how they're breathing. We're looking at, are they breathing shallow? Are they breathing deeply? Are they breathing rapid or slow? And anybody who is struggling with breathing, we want to go ahead and give them oxygen. For a medical patient, we'll begin with a 10 liters of oxygen on a non-rebreather. We can go ahead and evaluate their circulation, looking at the pulse. Is it fast? Is it weak? Is it bounding? Is it thready? And we'll also look at the skin of the patient. We're looking at the color of the skin. We're looking at the temperature, how it feels. Is it warm to the touch? Is it cool to the touch? And also if it's damp or dry. And then the last thing we want to look at is our patient going into shock. If the patient is going to shock, we want them to be lying down in supine position, cover them with a blanket, prevent heat loss, and give oxygen and transport. Once we go through all that X, A, B, C's, and S's, we'll make a determination: are we going to stay on scene and treat, or are we going to transport and get the patient to the nearest hospital? If the patient is alert or if there's bystanders around, we can then ask the questions, the OPQRSTs, and the sample questions. O stands for onset. What was the patient doing when this medical emergency occurred? P is provocation. What have they done? And has that done anything to make it feel better? Quality is, can they describe the type of pain that they're experiencing? R, is it radiating to other portions of the body? S, severity, scale 1 to 10, how does it feel? And then T, how long has it been going on? And then we can go on to the sample questions, signs and symptoms. Signs are anything the EMT can see wrong with the patient. Symptoms are something that the patient is describing to the EMT what's wrong with them. A, we'll record any kind of allergies they have. M, any kind of medications the patient's on. P, present and past medical history Has this event happened to them before? If so, how does it rate compared to now? L, our last oral intake of food or drink, and then E, events leading up to this. Once once we're done answering those questions, we'll go on and do a secondary assessment of the patient and try to formulate or get not formulate do a secondary assessment and then go on to take a set of vital signs. And the vital signs we want to collect are pulse, respirations, and blood pressure. We could look at their eyes, see if they're equal and reactive to light. Are they unequal, which could mean a head injury, and are they constricted or dilated, perhaps from drug use? And if you have a pulse oximeter, you can put that on your finger and figure out how much oxygen saturation they have. And we want to have that somewhere between 95 and 99%. Then we'll do a field impression, figuring out what we think is wrong with this patient, and then we'll go ahead and start our treatment and interventions. Last thing we want to do is transport the patient. Now, if we called for ALS, we have to determine how close ALS is. Do we wait on scene and wait for ALS, or do we want to rendezvous on the way to the hospital? Or is ALS still pretty far out that and we're closer to the hospital that we'll just transport on our own? And set of vitals for an unstable patient, we're going to be with life-threatening conditions. We're going to be taking vitals every 5 minutes. For somebody who is stable, we're going to be taking vitals every 15 minutes. And the last thing we want to do is a patient transfer care report. So we're going to give the person that we're handing the patient off to with higher medical training, we want to give them the demographics of the patient: race, sex, age, height, weight, and then we're going to determine or try to describe the mechanism of injury the best we can. Also, nature of illness. We'll go down giving the vital signs. And lastly, what kind of treatment was the patient given, and how did they respond to that treatment? Did the patient get worse? Did they stay the same, or did they get better? And that completes a medical assessment of a patient.